Um, let's get this thing started. Manish, Shah, UT Houston. I'm here to moderate today's fellowship lecture. So today we have the extraordinary privilege of hearing from Professor Matt Smyth. He's a simple country boy from Southern California, born with a surfboard in his hand. He then migrated to Cornell to be educated in the ways of skateboarding and chicken raising in coops. Along the way, he then decided to do medicine and ended up at UCI for a surgical internship and trained at UCSF. Then afterwards did a fellowship at the University of Alabama under Jerry Oakes, and then joined the faculty at WashU in St. Louis at St. Louis Children's. He is well known in the field of epilepsy surgery. If something can be done in epilepsy surgery, Matt Smyth knows how to do it and has done it and has published on it. He has 215 publications. He is training, he has trained many people. I think he's up to 20 years of fellows this year. And we're all very, very privileged to have learned from him. So without further ado, he's going to give us a wonderful overview on pediatric epilepsy surgery.
Thanks, Manish, for the kind introduction. You do need to work on your Southern accent. Your Texas twang needs a little bit of work, but I'm not the one to teach you that. So thanks for inviting me to give this talk and for introducing me. This is a really broad topic, right? So, pediatric epilepsy is very diverse in children, which makes it a very gratifying field to specialize in because there's lots of different techniques. And you can really impact the children and the families in a meaningful way with their quality of life. So it's very gratifying. Any of those of you on the call considering epilepsy surgery as a subspecialty, I really encourage you to think hard about it and feel free to reach out to me if you want to ask any questions about it offline. So let me get my slide deck going here. So I do have a couple of disclosures. Also, I'm going to talk fast because I packed like 70 slides into 30 minutes because there's just a lot to cover, and then we'll open it up to the various cases that the other faculty are going to present. So I've structured this talk with a few minutes on sort of the burden of epilepsy and intractability of seizures and the indications for epilepsy surgery. I'll talk a little bit about what a typical pre-surgical evaluation entails, and then we'll talk about some selective techniques and their outcomes. So we'll focus a little bit on temporal lobectomy and laser ablation, grid and stereo EEG-based studies and resections, talk a little bit about hemispherotomy and callosotomy, which are more unique to pediatric epilepsy. So first couple definitions. So what's a seizure? It's the clinical manifestation of abnormal excessive excitation and synchronization of a population of neurons. And what's epilepsy? The practical definition that's commonly used is recurrent unprovoked seizures separated by at least 24 hours. So in children, seizures are actually fairly common. About 1 in 20 kids will have at least one seizure during childhood, but most of these are self-limited, like a febrile seizure or an acute symptomatic seizure. But about a quarter of those children go on to develop epilepsy with recurrent seizures. So that means that the overall incidence of epilepsy in childhood and by default then in adulthood is 1%. We're not going to get into the details of seizure semiology and classification. That's more of a neurology talk, but you can, in terms of surgery, think of seizures along these two arms. So partial seizures often have a focal onset, and so the surgical goal is cure. And then generalized onset or multifocal seizures, often the surgical goal is palliation. And both of those types of surgeries have value. So about 3 million patients in the United States have epilepsy, and about a third of those are refractory. And so there's about 45,000 new refractory cases per year, which are all potentially a surgery candidate. So this is a vastly underutilized tool to help these patients. There's cost to the individual in terms of morbidity and mortality, cognitive costs and psychosocial costs, as well as mortality, morbidity. And there's, of course, there's a cost to society in terms of loss of productivity and then the healthcare costs associated with epilepsy. This was an interesting study. It's a 30-year follow-up of a cohort of over 200 children with epilepsy. And what they determined is that if you've got epilepsy, you've got a significantly increased risk of incomplete education, not being married, being unemployed, not having children. And you have a high rate of psychosocial impairments, mood disorders, and depression and psychosis. And then 20% of this cohort died during the study period. Some of that death is attributed to SUDEP, which is sudden unexplained death in epilepsy patients. This occurs in patients with controlled epilepsy at a rate of about 1/3 of 1%. It also occurs in patients with refractory seizures at an even higher rate that approaches almost 1% per year. So when I'm often counseling families about a large epilepsy surgery and they're worried about mortality in the operating room, I point out that a day in the operating room is much safer than living a year with epilepsy, whether it's controlled or uncontrolled. This is a classic paper many of you have probably seen from Patrick Kwan and Martin Brody. It was published about 20 years ago in New England Journal. And this paper really keyed in on the idea of medically refractory epilepsy and when to consider surgery. So of this cohort of patients, about half of them had seizures controlled with a single anticonvulsant. And once you fail one anticonvulsant, the chance of a second one being effective drops to under 15%. So after you fail 2 anticonvulsants, the chance of seizure freedom falls to 4%. So that's when it's time to start considering other options than medications. Now, this study was performed 20 years ago, and since then there's been about 20 new anticonvulsants, and it's moved the needle somewhat for certain disorders like Dravet syndrome, for example. There are some meds that are a little bit better than this, but still, generally speaking, if you fail 2 anticonvulsants, it's time to think about epilepsy surgery. So is epilepsy surgery a good thing? Yeah, I think so. This is a study with a 26-year follow-up of Sidney Goldring's patients. He was an epilepsy surgeon and chairman at WashU. He also did pediatric epilepsy before there was a real pediatric neurosurgery group there. And we looked at a cohort of 120 of his patients with 26-year follow-up. And what we saw is that even using techniques from the 60s, 70s, and 80s, durable seizure freedom was seen in about 57% of the patients. And there's a direct correlation with quality of life correlating with seizure freedom. So if a patient's a surgical candidate, you should really consider it, because if you can stop their seizures, their quality of life is going to go up. So a typical pathway is a patient will go through 1 or 2 anticonvulsants. Once they fail their 3rd anticonvulsant, hopefully they're referred to an epilepsy center where a pre-surgical stage 1 evaluation is performed. A stage 1 evaluation pretty much should always include an MRI scan, high resolution 3T if possible, an EEG video to capture ictal events, a PET scan, and neuropsychology. And then once these initial studies are performed, hypotheses are generated by the epileptologist, and then they're discussed at a multidisciplinary epilepsy surgery conference. And that's the model that most epilepsy centers will follow. Medical school 101, you got to start with clinical history and physical examination. There's a few things specific to epilepsy. Localization that you can pick up on exam, like Sturge-Weber has a port wine stain on one side of the face, for example. And you want to get a detailed seizure history because there are clues in the aura, the post-ictal state, the appearance of the seizures that might help you lateralize or localize the seizures. And your epileptologists are expert in this, but as an epilepsy surgeon, you can get pretty good at it too. And then you want to utilize, of course, your electrical studies, your interictal scalp EEG, which is typically done as an outpatient, and then your video EEG to capture ictal events, which is done as an inpatient. MRI is the mainstay of neuroimaging, but there's other imaging studies that are incorporated to help localize seizure onset. In adults, the neuropsychological evaluation is often important for handedness and language lateralization, but in children, it's extra important for developing, for establishing a baseline for development and for monitoring the progress of development with the disease ongoing or with the intervention to improve the seizure control. And then you can consider invasive monitoring as a pre-surgical evaluation, although there are actual surgical procedures to implant electrodes. So typical video EEG study, a patient comes in and is admitted, has their anticonvulsants tapered, you capture a seizure event. Here's a kid having a right-sided face and arm jerking movement. He turned out to have hemimegalencephaly and underwent a hemispherotomy. And then an MRI scan. So you're seeing lesions like mesial temporal sclerosis or focal cortical dysplasias. And interestingly, prior to the advent of MRI scan in the 1980s, these 2 diagnoses were actually were more commonly made post-mortem in epilepsy patients than pre-surgically. PET scans are incorporated in most epilepsy centers' evaluations. So this is a non-invasive qualitative way to measure the local cerebral metabolic rate. The FDG tracer is injected, and then an interictal PET is performed. And so the region of seizure onset interictally is actually hypometabolic. You can think of the brain being tired in between seizures. So we're looking for regions of hypometabolism like this frontotemporal zone here, which would tend to lateralize to the left frontotemporal region in that patient. Some centers incorporate magnetoencephalography into their workups. Not all centers have these devices, but I know in Houston, it's a heavily used tool. I think you guys have 2 meg scanners down there, or you did in the past, as I recall. So here's what the dipoles look like using the relationship of MRI to electrical activity. Meg scans are a little bit limited because typically they're interictal recording. So if patients don't have a lot of interictal activity, you're not going to see much in the way of dipoles. But if you're lucky enough to capture a seizure while they're in a meg scanner, you might have an ictal meg, which could be particularly helpful in localization. And then SPECT study is kind of the reverse of a PET scan. You inject a tracer right at the onset of a seizure, and then you actually catch hypermetabolism in the region of seizure onset because it's hypermetabolic. So there's many types of procedures to offer the pediatric epilepsy population. So they're ranging from very invasive radical surgeries like anatomic hemispherectomy and functional hemispherotomy, temporal lobectomy, as well as extratemporal lobectomies like frontal lobectomy or occipital lobectomy, large subdural grid and invasive recordings and resections, open callosotomy, and then a variety of less invasive techniques that have been used more recently, like stereo EEG implantation, radiosurgery, neuromodulation, laser ablation, and VNS. And then some of the more invasive techniques that we used to use purely using open techniques, now many centers and surgeons are adopting with less invasive approaches, like adopting laser ablation as an alternative to open temporal lobectomy, stereo EEG as an alternative to grid placement, laser ablation as an alternative for disconnecting like the corpus callosum versus open. And there's been an increasing use of responsive neurostimulation and deep brain stimulation, and actually using RNS to do DBS, given the current availability of devices for this. So for intractable seizures, you always have continued medical management. You have the alternative of a ketogenic diet, which is administered by a dietitian with expertise in this and monitored by an epileptologist. We have vagus nerve stimulation depicted here, and we're not going to get into that during this short talk. And of course, intracranial surgery, which we'll try and focus on. So if we're talking about intracranial surgery for epilepsy, it's worth reminding those who aren't familiar about the surgery outcome scores that are commonly used. There's the Engel classification, and more recently, the ILAE classification. Most papers you read are going to talk about the Engel classification, with Engel class 1 is typically seizure-free, Engel class 2 is rare disabling seizures, and Engel class 3 would be worthwhile improvement, often 50% or greater, or long stretches without seizures. And Engel class 4 is failed surgery, no worthwhile improvement. Epilepsy surgery benefited from one of the very few randomized prospective trials in neurosurgery. So these patients were randomized to best medical management or a temporal lobectomy. And what we see here on this Kaplan-Meier curve is that the surgical group had a statistically significant improvement in seizures at 12 months compared to the medical group, which, like the quantum Brody data shows you, they continue to be refractory and seize. So that's in adults. In children, is temporal lobe surgery similar? And the answer is actually, yeah. In this case, kids are like little adults if they have mesial temporal sclerosis. So the subset of patients who have mesial temporal sclerosis also enjoyed a very high rate of seizure freedom. But risk factors for poor outcome after temporal lobectomy in children include multiple seizure types, developmental delay, and non-mesial temporal sclerosis pathology, which isn't that surprising because in those cases, it's more of a diffuse onset versus MTS, which is a pretty focal onset. So as an alternative to open temporal lobectomy, which is a previously fairly common operation, it's actually becoming performed less and less frequently because of the advent of laser ablation. So many centers are adapting laser ablation platforms to perform mesial temporal ablations. This isn't a laser ablation talk, but to introduce the technique to you who haven't seen it, there's 2 different FDA-approved systems. There's one called Visualase, there's one called Monteris. They both work pretty much through the same thing. A MRI-compatible laser fiber is implanted stereotactically into the target, and then the laser energy is turned on while an MRI scan performs thermometry. And this Arrhenius equation is used to generate a thermal damage estimate. And then the thermal damage estimate follows pretty closely with the margin of necrosis on the scans post-op. The use of LIT was promulgated in a large part by the group in Emory, who published a pretty healthy series of laser ablation for mesial temporal onset, and also demonstrated there may be better parameters of language function by performing a focal medial laser ablation. You're not disconnecting the temporal stem or removing lateral neocortex. So just like the Rose trial of radiosurgery of the 2000s that showed similar measures with radiosurgery performing mesial radiosurgical ablations, laser ablation does a similar trick in terms of preserving verbal memory. In the pediatric group, Elsa Arrojo Quinones recently published this paper. Many centers, about 20 centers or so, contributed their laser ablation in pediatric epilepsy data. And if you wanted to drill down and see how the patients with mesial temporal sclerosis performed, they performed pretty well actually with laser ablation. And this includes the steep part of the learning curve. This was a cohort of patients that were published just in the first few years of the advent of laser ablation techniques. So I think that laser ablation is an alternative to open temporal lobectomy in children. This was the very first laser ablation case we did when I was in St. Louis. This was a teenager with complex partial seizures. They were refractory. She was cognitively normal, and in her dominant temporal lobe, she had this little abnormality that was a little bit concerning for a cavernous malformation because there's some susceptibility weighted artifact and this little area of gliosis there in the mesial temporal structure. So we offered laser ablation. She had a lateralizing and localizing EEG video. She had a SPECT scan, which lateralized to the left temporal lobe. And we did a single fiber posterior approach using the Monterra system to place the fiber along the hippocampus and amygdala area. And that had a nice result. She was Engel class 1, no deficits, off anticonvulsants. So that kind of got us started on the pediatric epilepsy laser ablation bandwagon back around 2015, 2016. Okay, so pivoting to invasive recording. So localization of seizures is critical to success. And so the mainstay of invasive localization that I was trained in the 90s and 2000s, and we used up until recently, was these large grid arrays. So these were very common in the pediatric population, more so than adults, for a few reasons. In children, the epileptogenic regions are often multi-lobar and more diffuse and require invasive large areas to record from, to localize. And then intraoperative ECOG only gives you interictal data. So you really need to have extraoperative capture of seizure onset, ictal onset. And it's hard to do awake craniotomies in children for mapping development cortex, but it's relatively easy to put a grid in, let the child recover, and then do cortical stimulation mapping in the epilepsy monitoring unit. So traditional open surgery would be a large exposure like this. You won't see this as much anymore with SEEG going on at most centers, but this is what it looks like. So big exposure, intraoperative mapping of motor cortex and central sulcus, lay down a lateral and interhemispheric grids and strips, and then close up. And you can map, here's the motor strip being mapped out, seizure onset confirmed as mesial frontal, and this patient went to a supplementary motor area resection. So this would be the falx, anterior, lateral, and posterior. This particular patient had a dense hemiplegia, which was not unexpected as an SMA syndrome, and went on to have a good outcome at a last 6-year follow-up, as I recall. We looked at our SMA resections. This included patients that were either lesional or non-lesional. As long as the criteria was that they had the lesion in the SMA area, they underwent a resection. And these had a high rate of seizure control. So operating the medial frontal lobe is actually a good place to go. And we also characterize the time course of the recovery of the supplementary motor area syndrome, which is a violation of the secondary motor area. And often you get rewiring, and the patients will spontaneously start moving their contralateral limbs, often at a week or usually by a month. And a handful of patients had full recovery, but it took several months for them to recover. A more challenging subset of patients to perform epilepsy surgery, and there's those with extratemporal non-lesional seizure onset. And so that subset of patients may enjoy only maybe a 50% chance of seizure freedom. And it's often very difficult to localize because you don't have features like an MRI lesion to guide your localization and your resection. We use grids for a long time, and grids are prone to complications. So we had a 13% reoperation rate using grids. And while we were messing around with grids in the United States, over in France, they've been using this technique for decades. So Jean Talleyrand and Jean Bancode were involved in pioneering stereotactically placed depth electrodes using frame-based systems and angiography to localize blood vessels. And that didn't really catch on in the United States until the surgical robot became available. We started using it around 2016 in St. Louis, and now the majority of epilepsy centers have a device such as this for stereo EEG implantation. So instead of these big open exposures, we can do these percutaneous multiple electrodes that are placed. So the protocol and the workflow is first at our multidisciplinary epilepsy conference, we would generate, our primary and secondary hypothesis. And if we felt that invasive recording was necessary to localize seizure onset, we would talk about invasive electrodes and say they're an SEEG candidate. Okay, we'll plan on SEEG. And usually at that point, we kind of stop the conversation and we plan on a secondary planning conference that's dedicated to electrode placement. So we'll meet with the epileptologist who knows the patient best, who's studied the scalp EEG. Then we'll work together to create a map for implanting all the electrodes. And then the neurosurgeon will then optimize those electrodes to avoid blood vessels as on their own, kind of offline. So here's a typical frontotemporal insular study. The nice thing about depth electrodes is you can sample the surface, but you can design your trajectories to, for example, pick up the frontal operculum and the cingulate, or the temporal operculum and the insula. Typically, orthogonal trajectories are preferred because it's easier to visualize in sort of a grid format like you can see depicted here. But sometimes due to pathology or prior craniotomies, you can do oblique trajectories as well. The patient's connected to the surgical robot, it's draped into the field, and then the robot will go from pre-planned trajectory to trajectory. Implantation is a twist drill, percutaneous, a hollow bolt is placed, electrode depth is measured, and then the electrodes advance through the hollow bolt and secured with a nylon cap. And then connected to the EEG amplifier to confirm that all the technical recording is going to work. Each electrode takes about 5 to 7 minutes once you're registered and running. So you can implant these cases in about 2 hours or less if everything's working well technically. With a grid, you would go to the ICU and watch them carefully because they had a big craniotomy. With SEEG, I prefer to get a CT scan immediately post-op, confirm the position of the electrodes, and also rule out hemorrhage. And if the CT looks okay, we go straight to the epilepsy monitoring unit and hook them up to the EMU telemetry right there. And then you can do your monitoring and mapping. And one of the nice things about SEEG is the patients really feel good after surgery compared to craniotomy. With a craniotomy for grid, the kids are puny, they're nauseated, anorexic. It takes them 2 or 3 days to feel better. But with this, the kids are up watching TV, playing games, literally the day that you implant the electrodes, and you get good quality recording right away. We'll often do seizure mapping, where we will stimulate the electrodes to try and elicit the stereotypical seizure. And then we'll wean their anticonvulsants after that to try and capture seizure onset. And then once we've captured all of our data, we bring them back under a light anesthetic, loosen the caps, unscrew the bolts, and put a stitch in each exit site. And I'll send the kids home the same day if we get the electrodes out at a reasonable hour early enough in the day. And then you have an option. You can go, if you feel like you've localized the seizures well enough, you can remove the electrodes and do your resection all in one go, or remove your electrodes and do your ablation all in one go. We prefer to sort of remove everything, take some time, digest all the data, don't feel like we're under the gun to make a decision, and then have another full epilepsy conference evaluation, and then bring the family back in our multidisciplinary epilepsy clinic to discuss the surgical options. So I usually do the definitive intervention on a different admission, although some centers will do it all on the same admission. So here's an example of incorporating a few of the technologies. This was at the time of this presentation, she was 18. She had seizures that involved her left hand and face. They were obviously drug resistant. And when she was 7, she underwent one of these traditional grid exposures and resections. So here's the central sulcus, primary motor cortex, grid placed. We localized her seizures to the face motor and sensory region and hand motor region, and we did not offer a complete resection for fear of giving her a deficit. So she had a partial resection of her seizure onset zone with some multiple subpial transections we did here, which now are more of historical interest. And then she came back, she got, with ongoing seizures, she had some improvement, but not seizure freedom. We obtained a MEG scan, which actually showed dipole cluster behind her area of resection. And we designed an SEEG study to sample in and around her resection cavity, focusing on where the MEG directed us. But interestingly, her seizure onset was anterior, not posterior. It was in the anterior bank of her resection. So we were able to elicit stereotypical seizures by stimulating, capture spontaneous seizures, and then we made a plan for RNS because we did not want to resect her hand and face motor area, particularly at age of 18, where a deficit would be pretty profound. So this is one of the first RNS devices we implanted. So this is responsive neurostimulation, FDA approved for treatment of 1 or 2 seizure foci in patients over 18 years of age. At the time that we implanted this was right when RNS was released, so we waited for the patient to be 18. We sort of had an idea that she would localize to eloquent cortex, so we were ready to do the RNS in her case. And so here is the exposure. So there's a small craniotomy to place the tray and the pulse generator in place. Here's a little burr hole cover where we place the depth electrode, and here's a CT showing where they are. And this video is just kind of showing the robot coming back on another day, guiding to the exact same trajectory we placed the SEG electrode into, and then dropping the stylet, and it lines up like perfectly with the SEG hole. So there's a lot of integrity and reproducibility with frame-based and with robotic-based localization. So you can be pretty confident in localization with the surgical robotics. She was watched overnight, wasn't really a craniotomy, so we didn't have to deal with opening the dura on a prior grid patient and dealing with all that. So her risks were lower, and she had relatively little pain and discomfort. And we did have an impactful result with the neuropathy. She's not seizure free, but she has significant seizure reduction with that option. In the last couple minutes here, I'll pivot to a couple other of my favorite operations. So hemispherotomy and callosotomy. So hemispherotomy is performed almost universally in children. There's a handful of adults who escape the surgery and still get it as an adult. But the etiologies typically involve unilateral hemispheric injury or unilateral hemispheric congenital malformation. So MCA territory infarction in the perinatal period is a common one. Hemimegalencephaly or malformations of cortical development involving one hemisphere or another one. And then we see Sturge-Weber and Rasmussen's encephalitis, and then trauma would be the other ones that make up hemispherotomy candidates. There's many ways to do a hemispherotomy. There's anatomic hemispherectomy. There's multiple forms of disconnections. I prefer the lateral approach that Johann Schramm showed me about 20 years ago, but others advocate a parasagittal vertical approach. The components of a lateral disconnection include exposure of the insula and the circular sulcus to allow access to the ventricle. By accessing the ventricle laterally, you're going to disconnect the corona radiata and all the outflow in the temporal stem. A selective amygdalohippocyampectomy, and then cut the corpus callosum in a transventricular fashion, a frontal basal disconnection, and then decorticate the insula. At the time we published this series, we had about 50 patients, and the seizure freedom rate is very high with a well-selected hemispherotomy patient. So the way I tackle these is with sort of, I think, about 7 steps to it. So after positioning, cranial fixation, parallel to the floor, this was a relatively large incision. I make them a little smaller now with this following the superior temporal line. A frontotemporal craniotomy and exposure of the dura based pretty much over the sylvian fissure, a little bit more temporal than frontal exposure. Expose the sylvian fissure and then do a very wide aggressive split of the sylvian fissure, and then resect the frontal operculum and the temporal operculum to expose the entire insula. Here's some of the M3 branches there. And so once you've resected that the opercular window, you can see the insula, and then you can work around it circumferentially. So step 3 is to enter the lateral ventricle, follow it all the way around to the temporal horn, and then I come down along the superior temporal gyrus amygdala and resect the amygdala, isolate the hippocampus and resect it on block. So here's midbrain here, his hippocampal body coming around, and here's hippocampal tail. I usually coagulate the choroid plexus and then resect the hippocampal tail all the way back to the subsplenial region to cut the fornices. And we pivot back to the lateral ventricle and find the intracerebral arteries through the roof of the lateral ventricle through the corpus callosum, and then begin to divide the callosum from front, following it all the way back. Here we are connecting the back of the callosum with that subsplenial division of the fornices to connect the dots back there. And then we're back. Then we're down to just a couple last steps. The frontal basal disconnection. You follow the intracerebral arteries proximally down to the cranial intracranial fossa, and then at the end you decorticate the insula, shown there. So those are the steps to that lateral approach, which I'm most familiar with. And then using that approach, here's a paper we looked at EVD usage and postoperative pyrexia in hemispherotomy patients. Seizure freedom rates about 96% with favorable outcome. And the last procedure I'll touch on briefly, because it's unique, mostly unique to children, is atonic seizures, drop attacks in the Lennox-Gastaut population. Callosotomy is the primary intervention surgically for drop attacks. It's very effective. That video is showing you what a drop attack looks like when a patient loses tone. These patients often have facial injuries, dental injuries, scalp and head injuries, and broken bones from their drop attacks. The open approach I favor is midline, supine, interhemispheric approach, single retractor, gently retract the mesial right frontal lobe, dissect down to find the intracerebral arteries, divide them to find the corpus callosum, and then I like to do a nice wide interhemispheric exposure before I dive into the callosal disconnection. And then work anteriorly first to follow, here we're working ourselves forward to follow around the genu, down to the rostrum, trying to stay between the two lateral ventricles. Here's the septum pellucidum there, showing the right ventricle and left lateral ventricle. And we're working anteriorly to complete the disconnection. And once the front's done, you sort of drop the head of the bed, angle the scope posteriorly, and then you follow the body, isthmus, and back to the splenium. I've tried using CO2 laser. I've tried Sonopet, Kuza. I found it easiest though just to use bipolar and suction to cut the corpus callosum, experimenting with different techniques, but different surgeons will have different ideas about that. Drop attack control rate's very high with callosotomy. And in our series, in the first 50 or 60 patients, we saw that patients who had an upfront complete callosotomy had better seizure control. So we sort of migrated using upfront complete callosotomy on the lower functioning kids. And then the corpus callosum is kind of a unique structure because it's bounded superiorly and inferiorly by CSF. So it makes it appealing to try laser ablation on. And here's a paper Jared wrote when he was our fellow, looking at our first 10 or 12 patients that we used laser ablation for callosotomy. And here's typical trajectories that are used to place the laser fibers for an anterior 2/3 disconnection. And here's the trajectories we can use for a 3-fiber complete callosotomy. You can see the lateral oblique fibers for the genu and the splenium, and a horizontal fiber for the body. Here's what the setup looks like using ROSA for targeting. Bolts are placed. I like to try to use the eyebrow if possible to hide the incision and behind the hairline here. Here's what the trajectories look like with the fibers in place. This is using Visualace for the thermal damage estimate. This is a video fast forwarded to show the ablation. We're pulling the fiber back a few millimeters at a time to complete the ablation. And here's what a post-ablation scan looks like. The ring of enhancement correlates pretty nicely to necrosis. And here's what ablation looks like within a few weeks of surgery. And then I think this is a year out after laser ablation compared to open disconnection at the top. This procedure takes a little bit longer using laser than open because of this technical issues with transportation and fiber placement and laser ablation. But there's no blood loss, no pain after the procedure. There's shorter hospitalizations. And Jared and Becca and Diane, who's a resident at WashU, are working on a retrospective series of about 100 callosotomies. And this is Diane's work showing the Kaplan-Meier curve, showing similar outcomes with open versus laser ablation at 5 years out. So that's what I packed into 30 minutes to give you an overview of the diverse number of types of epilepsy surgeries. So I'm going to stop and give it back to you, Manish.
I mean, that's just absolutely incredible. I mean, I saw Professor Pollack take notes. He's going to go home and challenge Professor Abel, Pittsburgh, and just start doing these surgeries himself. So as Bharat, my fellow, knows, if you don't know the 7 steps of the Smyth hemispherotomy, I'm going to kick your ass out of the room. That's how we do it. So any questions from the trainees? Bharat can say yes to that, because that's I actually did that. All right, you know what? I have some questions. Okay, so this is the fundamental important question. How do you convince the neurologist of what AED failure is? So a neurologist who lives in God knows where can say, hey man, I got this patient down from 5 seizures a week to 3 seizures a week. Isn't that a success? I don't understand. How do you deal with that?
Yeah, I mean, we've been talking about this for as long as I've been, like 20 some years I've been dealing with this problem. Usually the epileptologists in the epilepsy center don't think like that, but it's the community and referring neurologists do think like that. So there really is a pattern of refilling their prescriptions, taking their seizure diary, and just sending them back for another 6 months. And your question is like, how do you impact that? And I think the best way to impact it is doing a good job with the epilepsy patients they refer to you, communicating with them abundantly. We invite them to our epilepsy surgery conferences so they can participate as much as possible, and engaging them with the long-term care of these patients so they don't feel like they're going to lose the patients if they refer them to an epilepsy center. We want to get the patients back to them, but help co-manage their seizure medications even after surgery. I don't really have a great answer. I mean, it's education. Some of it's probably generational too. I'm hopeful that the new generation of neurologists are more comfortable with epilepsy surgery. And I'm also hopeful with the less invasive techniques we've been talking about, that barrier to refer is going to get a little bit lower, because it's not perceived as so barbaric as like, big grids and big hemispherectomies.
That's a great answer. I mean, it's a challenge. Yeah, I loved it. Professor Pollack, if you have an answer to that question, because we can all do a great job, but we can only do a great job if the patient's referred to us. And that's a big, big interest in the community for the community neurologists. So I don't know if Professor Durham, Professor Pollack, Professor Leonard, if you have any insight to shed on that, aside from, I would tell all the trainees, do the best job you can do for every patient and make sure your referring physician knows that. Contact them directly, take good care of them, because they're going to take good care of the patient and refer more to you.
Yeah, we have a nurse navigator who's dedicated to our epilepsy surgery patients, and she works hard to communicate frequently and freely with the referring epileptologists and the families, and I'm hopeful over time that will help build referrals as well.
Awesome. Well, maybe for the the next academic talk, we can go to Professor Pendrick, and he can teach us a little bit about open resection of the temporal lobe. We all love that anatomy. All you budding epilepsy surgeons, you too should love this anatomy.
Sure, I'd be happy to.
Sorry, to introduce it, you just introduce yourself.
Okay, sure, yeah, no problem. My name is Dr. Jonathan Pendrick. Friends call me JP. I'm one of the pediatric neurosurgery attendings over at Nationwide Children's Hospital, and one of my areas of focus is epilepsy surgery. So I'm going to share. All right. Okay, and let me just get into presentation mode. All right, can everyone see that pretty well? Yes, got a thumbs up. All right.
Yep.
So awesome. So thank you very much, Matt. That was an awesome, awesome overview, awesome talk. So I'm just going to give a brief talk, really just a case presentation about standard anterior temporal lobectomy and amygdala hippocampectomy. The boundaries of resection, kind of most importantly, the posterior extent of resection, are typically determined by the laterality and the dominant hemisphere based upon either cognitive neuropsychology evaluations, functional MRI, but based upon where language dominance is. So on the dominant hemisphere, which typically 90-95% of the time would be left hemisphere, the posterior extent of resection would be about 4 to 4.5 centimeters. And then for the non-dominant hemisphere, about 5 to 5.5 or even greater if there are suggested indications for extending it more posteriorly. But the important thing to remember is that a brain MRI, positron emission tomography, or invasive monitoring, if it's performed, and/or pathology may dictate the boundaries. So if there's a neuro-oncologic lesion which extends more posteriorly than the standard boundary, then obviously one would choose to extend the resection more posteriorly to adequately treat the pathology. And just to review the neuroanatomy, these are just some schematic diagrams showing you the typical regions included in a standard anterior temporal lobectomy, which would include the middle temporal gyrus, inferior temporal gyrus, the occipital-temporal gyrus or fusiform gyrus, perihippocampal gyrus, and then the mesiotemporal structures. Okay, so it's typically a combination of the lateral neocortex as well as mesiotemporal structures like the amygdala and the hippocampus. And then this is just another schematic diagram here on the right of following the lateral neocortical resection and entry into the temporal horn of the lateral ventricle, which is one of the main anatomic landmarks for this type of resection. You can see the roof of the temporal horn of the lateral ventricle marked by the choroid plexus, and then the uncal recess, which is this medially projecting cleft in the ventricle, which separates the amygdala anteriorly and the hippocampal head posteriorly. Okay, so to keep this brief, just jumping into our case presentation, we evaluated a 7-year-old right-handed male with a history of systemic juvenile idiopathic arthritis that was in remission and non-related medically intractable epilepsy. The child had onset at 4 years of age, and his seizure semiology included focal non-motor seizures, which involved behavioral arrest and oral automatisms. As expected, the scalp EEG LTM demonstrated some interictal left frontal and temporal discharges. I mentioned the as expected for temporal discharges because of the oral automatisms and behavioral arrest, and then some intermittent left temporal slowing. And then ictal onset was suggested within the left frontal and temporal regions, and better ictal evolution of the left temporal region. Also, we had a cognitive neuropsychology evaluation that suggested left temporal involvement. He had a brain MRI, which was initially reported as normal, but as an important teaching point, sometimes re-review at epilepsy surgery conference, where either focused review, where a neuroradiologist spends more time on the imaging, or focused review based upon additional findings like positron emission tomography, can help direct a neuroradiologist's focus to a particular area. So re-review at our epilepsy surgery conference revealed subtle blurring of the cortical and subcortical margins within the left inferior temporal and occipital temporal or fusiform gyri. And we had a positron emission tomography demonstrating left temporal hypometabolism, which you can see here on these two axial slices. One, just the standard raw images of the positron emission tomography, and then two, this is the kind of the Z-score labeling, which is compared to the standard population, and you can see a clear abnormality of hypometabolism in that left anterior inferior temporal region. So based upon the good lateralization but insufficient localization of seizure activity, we then proceeded with a stage 1 intracranial epilepsy surgery, which involved stereotactic EEG, which Matt had already discussed, which involved insertion of 12 stereotactic EEG depth electrodes within the left temporal and frontal regions using robotic stereotactic assistance. And then these are just some post-operative MRIs. So I think we have a similar workflow. We obtain intraoperative head CT to confirm accuracy of the depth electrode leads, and then we actually obtain a post-operative MRI neuronavigation to ensure that we have exact localization of each depth electrode. And then we also send our patients to the epilepsy monitoring unit post-operatively. So during phase 2 monitoring, this patient had interictal epileptiform discharges, subclinical electrographic seizures, and ictal onset within the left temporal pole and the left hippocampal head. And then during direct cortical stimulation mapping with these depth electrodes, we observed speech arrest along the left superior temporal gyrus, which would be anticipated. We've also had a functional brain MRI on this patient, which showed left hemispheric language dominance. So you can already see concordant data in terms of functional mapping, as well as concordant data with our phase 2 monitoring, as well as these phase 1 monitoring findings. So after depth electrode removal and rediscussion at our epilepsy surgery conference, we offered the patient a standard anatomic dominant hemisphere left anterior temporal lobectomy and amygdala hippocampectomy. We used our standard boundaries of resection for a dominant hemisphere, which would be about 4.5 centimeters from the anterior temporal tip. And again, our main anatomic landmark that we search for initially is the temporal horn. And then this is just an intraoperative image following removal of the lateral neocortical structures and the mesial temporal structures as well, the amygdala hippocampectomy. This is one of the key tenets of the case, which is to preserve that mesial pia, which will protect you from violating any of the critical neurovascular structures. We also used intraoperative pre and post-resection electrocorticography. We did not see any abnormal post-resection electrocorticography findings that would suggest the need for any further resection. And the operative pathology was a focal cortical dysplasia type 3A, which would be anticipated for a patient who has lateral neocortical disease, cortical dyslamination, as well as hippocampal sclerosis. And we just saw this patient in clinic this past week, and he's doing great. It's early after surgery, only about 3 months, but he does have lack of any recurrent seizure activity. He's doing very well functionally and cognitively without any speech impairment. And this is just some post-operative MRI demonstrating the extent of resection. Typically, for an amygdala hippocampectomy, we try to extend the resection posteriorly to the level of the at least the lateral mesencephalic sulcus of the midbrain, but really truly, if you can get to the quadrigeminal cistern and ensure resection of the hippocampal body to the junction with the tail, that's typically sufficient. And that's the MRI just demonstrating that here. And that's it.
That was awesome. I mean, that's like the perfect segue to Jared talking about lit. So Professor Rowland. Professor Rowland is a Texan, went to Texas Tech, and was amazing as a med student in Dr. Luthart's lab. I recruited him to do residency at WashU. And I was fortunate to be co-residents with him. And then he did a fellowship at WashU and went on to UCSF and is now back at WashU doing epilepsy surgery. So he's going to talk to us, give us a brief, hopefully condensed, version of lit.
Thanks, Manish. Let's see, I've got my slides shared here. Let me get my screens organized so everybody can see that okay?
Yep.
All right. So this patient, I'm going to go through a quick little case presentation, much like Jonathan just did, about a patient who had a recurrence of seizures after a frontal lobe resection. No disclosures, so I'll speak a little bit quick, but feel free to interrupt me if we need to. I don't necessarily have to get to the end of this if somebody has something interesting they want to stop me about. This patient is now a 6-year-old female with medically refractory epilepsy. Her seizures began at 3 weeks of age, and she previously underwent a left frontal resection at 9 months of age. And this surgery was done by one of the world's foremost pediatric epilepsy surgeons. Fantastic work. You couldn't ask for a better neurosurgeon to do this case. So, of course, this person had fantastic outcomes initially, at least. During this first case, they did use some intraoperative electrocorticography, just like Jonathan described for his temporal lobectomy, found a type 2A cortical dysplasia, and was seizure-free for 12 months. Unfortunately, did have some recurrence of seizure, went back for a repeat resection at 23 months of age, and after that was 2 years seizure-free. Unfortunately, continued to recur. This one, I think, is one of the reasons why I like to talk about this is not because I like to talk about people who didn't have permanent seizure freedom, because those are great cases to talk about, but to emphasize the fact that sometimes the seizure freedom is best visualized with a Kaplan-Meier curves. These aren't necessarily binary results, as sometimes we think some people think about for epilepsy. And there is some fall off over time and some recurrence with seizures over time. And so your outcomes at 6 months or 1 year or even 2 years sometimes are not the same as they are 5 years or more out. So this patient came back now 2 years after surgery or after their last surgery, had a VNS placed that had some benefit from. One of the other things that occurred over time was our improvement in identifying genetic causes of epilepsy. So this patient, after their VNS was placed, was found, underwent a genetic workup, and then this gene panel found a DEPDEC5 variant, which is well known, well characterized for specific types of focal epilepsy. When you review this patient's family history, it's pretty clear that they had an genetic epilepsy. The father with epilepsy that was controlled by Keppra, paternal grandmother with also had an identified DEPDEC5 mutation, paternal uncle with epilepsy that wasn't well characterized, but this was clearly a genetic epilepsy, and now we have identified the gene that caused it. It's interesting that this specific gene mutation is associated with a focal, often focal epilepsy. It's an enteropathy, so there are some I believe Seattle has a clinical trial actually using I believe rapamycin, one of the mTOR inhibitors, specifically for this type of seizures. But at this point, the patient is medically refractory, having debilitating seizures, and their anti-seizure medicines are not controlling things. Physical exam is pretty reassuring, has had some significant cognitive delay over time, no focal deficits in her cranial nerves, but does have a mild to moderate hemiparesis, affecting the leg a little bit more than the arm. Has tried multiple anti-seizure medications, and has a couple of different seizure types. Her most bothersome, most consistent type of seizure is one that begins with this very difficult to characterize, but appears to be a fear. She screams in fear and runs to her family, her parents. This can occasionally progress to rightward eye deviation and full body stiffening, so it occurs multiple times per day. One of our other seizure types that's pretty well characterized starts with the stomach and chest pain that also occurs usually multiple times per day, and then potentially some other seizure types that aren't as well characterized or consistent. Her scalp EEG does show an ictal EEG that localizes probably to the left temporal lobe. A little bit difficult to tell if it's also from the left frontal area given the prior resection. And does have some interictal EEG that appears bilaterally. This is her current MRI that we're working with. There we go. And as you can see, the prior area of that frontal resection. So this is the anatomy that we're currently working with. And of course, we have the scalp EEG, and we have her seizure semiology. So we get to this point where we say, what are our options currently? Invasive monitoring is one to further localize this. Her prior resection was lesional. There was an apparent lesion on her MRI, but there's no longer an apparent lesion. We would certainly think that adjacent to her prior lesion or prior resection cavity would be high up on our list about the seizure onset zone. Similarly, from that seizure semiology, that kind of fear response can also be frontal, can also be temporal, can frequently be insular in origin. So those are big places that would be high up on our list if we were going to consider monitoring. Of course, SEEG and electrocorticography are a common methodology for doing such a thing. Hemispherotomy was discussed. She already has a mild to moderate hemiparesis. We felt like this was clearly a focal onset, lateralized that left hemisphere, and completing the prior frontal resection either with a more extensive disconnection or a complete functional hemispherotomy was discussed. She's already had VNS, but DBS would be another neuromodulatory option that would be considered for her. Ultimately, we decided for stereo EEG to hopefully localize what we felt was a focal onset. So when we get to that stage, of course, we've already talked a little bit about how we think about some of those electroreplacements. One of the things that we always emphasize is to get to that planning stage, we need to have a pretty good hypothesis of what we're looking for. When we're doing any kind of sampling or invasive electrophysiology, what we're sampling from the brain is relatively sparse as far as the cortical mantle goes. Whether it's ECOG or stereo EEG, we're still doing a relatively sparse sampling of that entire cortical mantle. So we need to have a pretty good hypothesis of what we're going study before we do some kind of invasive monitoring. Here, of course.
Can I interrupt you just for the
Please.
trainees? So why do you do SEG versus, going straight to resection? How many hypotheses does your group need to investigate?
Yeah, that's
Right?
a very
If
good
you only
question.
have one hypothesis, well, what's the point? You just go and whack it out. I mean,
That's a very good point. So for instance, for her, one of the things that we did have a long discussion about was that there is still some frontal lobe that's probably anterior to motor, and she had such a great response previously doing extending that resection. Why wouldn't it be reasonable to just continue to repeat that frontal lobectomy? Ultimately, the thought was that there's a chance that the reason why she's not having sustained response is it's not entirely frontal, that it could be more temporal or insular, which was the motivation for stereo EEG. For instance, you could also imagine electrocorticography, but that's much more difficult to study the insula. Not impossible, actually, but much more difficult to study the insula. And we, for all the people on the call, either do know or should know, the insula is not infrequently one of those areas that can confuse us and make something that looks like frontal or look like temporal, but it's actually originating in the insular area. And maybe that's one of the reasons why we have, lack of sustained response from our frontal or temporal resection, is potentially there's some part of that seizure onset zone that's actually in the insula. So here's kind of one way of diagramming that. I usually end up doing a lot of different ways of modeling this, but this is a quick way of showing where those electrodes sit in a rough kind of cartoon. The images on the bottom are a reconstruction from Curry, and the blue electrodes are on the left hemisphere, and there was 3 electrodes on the right hemisphere. Again, one of the big concerns that we had, because that interictal was appearing bilaterally, we wanted to make sure we weren't missing some multifocal onset. So we put some electrodes in the right side. When we do bilateral sampling, we try as best we can to have mirrored or homotopic regions. So for instance, one of those anterior insular electrodes, we made sure to mirror that as close as we could on both sides. And then we put 2 electrodes in that frontal region that were closely mirroring the posterior margin of our resection cavity, where we were monitoring with our left hemisphere. Here's the way that those electrodes look once they're placed. I don't necessarily restrict myself to the purely lateral or orthogonal electrode placement. I do a lot of that, but as you'll see here, a lot of these electrodes are coming in somewhat parasagittal from the top down. They're crossing over quite a bit as I was trying to kind of walk that fine line between the posterior resection cavity and also get some of the proximal portions of those electrodes in that frontal lobe and some of the deep portions of those electrodes either in the insula or the cingulate. Again, with those targets based off of seizure semiology with the fear component. Here's how I usually end up looking at those electrodes post-operatively to compare where that seizure ends up. I use ROSA most often, as Matt had described earlier. A lot of different ways to skin that cat, a lot of different surgical robotics out there, but this is just one way to do it. One thing I like to do, I think it's a nice little trick, is when you bring it into your navigation software, get your post-operative CT and window it down to where it's almost a binary kind of white and black. Once you've done that, you can then blend it with your MRI as such, and it ends up showing really nicely where those electrodes are. ROSA has a nice feature also where it turns one red. And so now your electrodes are red. That helps you differentiate it from the blood vessels that might be showing up with contrast. You can see as you're kind of scrolling around through the trajectory itself and how well that trajectory lines up with your actual electrode placement. Because not only are you need to know where you planned to put those electrodes, but where those electrodes actually ended up. Every now and then that can be different. So it's a nice little way of confirming those things. Ultimately, this person's results were that she was having seizures in pretty much everywhere we put an electrode. But the most important part was that very severe, most debilitating seizure that bothered her so much was consistently localized to that anterior insula. Unfortunately, every electrode showed some sort of seizure onset, including the contralateral hemisphere. So ultimately, what we described when we were deciding what to do for this patient, it ruled out a hemispherotomy. We saw a clear seizure onset from the contralateral hemisphere, so that's not an option. DBS is not excluded. It could potentially be an option in the future, but given how severe that most bothersome seizure was that was arising from the anterior insula, we thought a focal treatment was an option. Certainly, laser ablation or radiofrequency ablation through the SEEG electrode are both options for us. We ended up choosing LIT to that anterior insula. Here's how those trajectories look. I ended up using 2 trajectories for a variety of reasons. The ablation looks about like this. If this video will play, yeah, about like this, which you've already seen some examples from Matt's slides. This is the way we ablated that anterior insula, and her outcome was actually fantastic. That targeted seizure type, again, this was a palliative intervention. She had a fantastic response. She has no longer had any of those most severe, very debilitating fear-induced seizures since surgery. And actually, her other seizures had a significant reduction as well, probably about 50% reduction in her other seizure types, but obviously not seizure-free. So her family are very happy with those results. Again, it's very palliative, and so there might be future interventions for her. DBS is still an option, but with her multifocal onset, we're probably not going to be talking about a cure for her. So again, one of the reasons why I liked talking about this case, not because it was the Ingo 1 classification that we all shoot for, but it was a really important example for me of saying, this is why I'm going to sample certain areas of the brain, why I'm going to sometimes look in bilateral hemispheres to make sure I'm not missing something, because I don't want to put myself into a situation where I'm putting somebody through a procedure that I could have proven to be not successful if I had fully sampled the right areas in her brain. So that was the presentation. Sorry, I went through that very quickly, but that was packing quite a bit of a case into a short amount of time.
That was really phenomenal. I mean, there's a lot of sophistication in the presentation there. You know, like you didn't name the professor. That was really good. He's gonna have to update his papers. But two, I think it's critical to know that just because somebody has a genetic epilepsy doesn't mean that they're not gonna have a focal problem, and that focal problem, even though you palliate it or you think you've treated it, doesn't come back later to be needed further treatment or palliation later. So it's a game that you have to play to optimize quality of life over time. That was really great. I mean, you know, the other thing in epilepsy surgery is you don't always get a fresh head to deal with, right? So you have to know what to do when it's not fresh. So that was really wonderful. If we have a few minutes and there's some interest, I think Dr. Raju has we tailored it to 5 slides on RNS, which is probably not enough justice, but I mean, if Matt Smyth can talk about all of epilepsy surgery in 32 minutes, then I think 5 slides for RNS is reasonable. So Parth is our epilepsy fellow this year, pediatric fellow in July to June. So he's got 2 years with me.
For the opportunity. I'll be presenting a case of neuromodulation. Sorry. First of all, no disclosures, and thanks to all the mentors at UTHealth, especially Dr. Shah for the opportunity. And regarding the case, there's a 17-year-old female presenting with seizures since the age of 10 years. And the semiology was classified as epileptic paroxysmal episodes with 2 types of semiology. One is a dyscognitive or a complex partial type of seizure with staring skull occurring every weekly around 10 to 15 seconds. And other type of seizure was a versive seizure ending in a tonic type of seizures. Most of the time, 95% of the time, these versive were right versive seizure, and in remaining, it was a left versive seizure, and these were 2 to 4 per month. And we sometimes triggered by physical activity. And we evaluated initially phase 1 study was done. The video EEG results were multifocal bilateral onset. Then the high resolution structural brain MRI was also normal. MEG was showing bilateral mirror cortex spikes. Then the phase 2 evaluation stereo EEG was done, which again showed multifocal bilateral independent onset. So considering this phase 2 and phase 1 evaluation, so we offered VNS initially for the patient, and VNS was placed. Post VNS, we realized the VNS was not satisfactorily controlling the seizures, and we had to do a phase 3 evaluation with repeating the video EEG as well as MEG, which again showed the similar findings. So at this point in time, so we decided to go for neuromodulation, intracranial neuromodulation. The options were either DBS or RNS. So regarding the intracranial neuromodulation therapies, the indications were like diffuse generalized epilepsy, as in this case. Previously, there were only there were only option of VNS or corpus callosatomy, but now we can go ahead with intracranial neuromodulatory therapies. And other indications like when the seizure onset is bilateral, including bilaterally involving the mirror cortex like hippocampus. And also, when the seizure onset is in the eloquent cortex where the surgical resection is impossible. The options were either using open loop deep brain stimulation, usually involving the anterior thalamic nucleus, and we can even target other thalamic nucleus like centromedian as well as medial pulvinar, or use a closed loop responsive neurostimulation. We commonly use bilateral centromedian nucleus, but even in this case, we can use other thalamic targets like anterior thalamic nucleus and pulvinar, depending upon the predominant seizure onset. So I briefly explained the responsive neurostimulation. We use 2 electrodes placed bilaterally in thalamic subnuclear, as I described earlier, or hippocampus, or it can be somewhere in the cortex. So it can be anywhere on the cortex. Usually, if it is the seizure onset is deeper, we would have evaluated with stereo EEG and then placed 2 depth electrodes, either in the thalamic cortex, thalamic nucleus, or the hippocampus. If it is cortical onset, usually you will evaluate with grids and place electrodes, tip electrodes on the surface. These are off-label use in pediatric cases, and also these are for non-cortical targets. And usually the requirements is usually we need 8 to 9 mm of skull thickness, because for the placement of the VNS stimulator, RNS stimulator, we need at least 8 to 9 mm of skull thickness. The target here we see, we show the targets, commonly used targets like pulvinar and centromedian. Anterior thalamic is not shown here. And this is the case which we have performed, where we placed bilateral centromedian RNS. This is the positioning Dr. Shah prefer a frame in these cases, because the target is very small and even the entry points are more posterior to the coronal suture, so we can easily target using the frame. And in the images, you can see the segmentation of the centromedian nucleus, which is done by Dr. Shah. So we can use, there are many ways of identifying the centromedian. Anatomically, we can use atlas-based identification of the centromedian nucleus, or the segmentation of the radiological image. So Dr. Shah prefers segmentation technique to identify the centromedian nucleus. And regarding the targeting, also the other problem is identification of the centromedian nucleus. So even with 7 Tesla, it is very difficult to identify the centromedian nucleus because of the location and the size of the centromedian. And the common sequence which we use at UT is FGATE, which most of the time clearly identifies centromedian. And if you use FGATE and algorithmic segmentation, that gives more accurate localization of the centromedian. And these are the other methods which are used by, even different tiles and different universities. But we use algorithmic segmentation with FGATE. And at UTHealth, we have 4 cortical implants as of now, and 1 centromedian thalamic implant. And what centromedian thalamic implant is the case which I showed has 3 months follow-up, and the stimulation is on till no complication till now, and the results are good. Patient seizure controls are better, but still it is too early to decide, comment on the outcome of this patient. And the complications are rare, and as you, it's obviously because the Shah is cautious. And yeah, that's it from me.
Great.
That was great. Can you go back 2 slides? So this is kind of getting to be the state of the art, and sometimes, as we all know, Professor Smyth can tell you, sometimes the state of the art leads you down the wrong path. But sometimes one day we'll probably be back to doing more open cases. I don't know. We'll see what happens. But this is just it's like the new candy for neurologists in the community. And that's why I started out during Dr. Smith's talk with that question. Neurologists in the community are very excited about RNS, even if it's not superior to things like LID and SEG. For some reason, they're very, very excited about this. In our experience, at least, and from everything I've seen in my review of all the literature, the frame is probably better for tiny targets than the robot. After you put one electrode in with a robot in a 2 millimeter target, you have to worry as to where the next electrode is going to go. And in the CM, medial to the CM is the ML. Doesn't really matter if you're a little medial, but if you're even marginally lateral, you end up in the VPL, and you can cause tremendous quantities of pain in the patient. And we've seen that in some of the adults here. And so I'd just be, to all my friends out there who are going to put in RNSs in the thalamus, be very cautious as to how you decide to put this in. But that's kind of an overview. So between 4 speakers, I think hopefully the group has a very good understanding of what is medically refractory epilepsy and how we go down the pathway from minimally to maximally invasive treatments and neuromodulation in what can feasibly be done in like an hour and 10 minutes. But we'd love to answer some questions.
Those are great cases, guys. Manish, so this was your first CMT, right? So did you have Nitin help you with it, or?
No. I'm very comfortable with the frame. I use the frame like quite enough, I think, to do. I like to use the frame for every SEG case for just a rigid fixation points. We have a lot of good experience with that in our OR. But in terms of using the arc, if it's a deep target, like the high, if we're doing like a HH lit or something like that, where if we're off by a millimeter, everybody's going to be unhappy, then I like to use the frame. And here, I think the biggest thing is the paradigm for Nitin had done about 11, and I think he's used the frame for some, and then he's using the robot more. But with the number of patients who had VPL side effects, I was a little concerned with that. And then also, what's really interesting is that there is no equipoise in terms of determination of what the CM is and where it is in every patient. So people use something like the Morale Atlas. That can be really off if your third ventricle is of a different size. Just like in DBS for the STN. I mean, there are a lot of people who still use like the stealth Morale Atlas base, like they'll click a number or they'll click a button and then they'll put the electrode in, and yeah, hopefully it'll work. Hopefully they're doing microelectrode recording. You can't do that with the CM, and there's a lot of disagreement on exactly how to even find it. You can't see it even on 7T. The Nautilus trials we discussed yesterday, they want you to do it a certain way and to get an MP2 rage, but they have a perfect case where they show the CM on this MP2 rage. It's not always like that. So anyway, those are, I think that the biggest challenge is going to be in really localizing the CM. If we, I think I gave a talk about this a couple of weeks ago, but if we were wise as pediatric epilepsy surgeons, we should make a registry with images and see where the electrodes actually end up and see what kind of side effects we have and be honest about it, so we can all be doing, offering something good for our patients, rather than having like one case series with 4 CM RNSs placed by a robot where something might have been off, or somebody didn't report a VPL finding. Those are just my thoughts. I think like this is a very at the edge, state of the art kind of thing. And having watched my adult colleagues do some things that I wouldn't ever do to a child, like I wouldn't randomly sample the thalamus with SEG, knowing that I've cured 2 patients with SEG. Like, we're doing something with these electrodes, and there's some damage that happens. I think it would be good of us to do some kind of registry or forethought. My thoughts.
Hey, JP, I saw that you do MRI after your SEG implants. So who else here does an MRI with fresh EEG electrodes in the head? Anyone? So I do a CT and I co-register to the preoperative MP rage. I mean, SEG electrodes are MRI conditional compatible, right? But
Yeah, they are. I mean, we also perform a CT scan, intraoperative CT scan, which is of low quality, and we co-register it with our preoperative planning just to confirm accuracy before we leave the operating room. But we certainly could just use the co-registration. But we've talked with our neurology colleagues, and they like having the most up-to-date MRI with depth electrodes in place so they can use it for their Curie software and planning. We've discussed with the company and the rep. They've put in for an FDA application for approval. That was a while ago, and I don't really know what the status of that is, but all of our radiology technicians, they take the necessary precautions in spreading out all of the depth electrode tails just to make sure that there's no additional coil formation or any loop that would be formed. So I understand, but I know I'm surprised that nobody responded. There are other sites which perform MRI following placement. So unfortunately we haven't had any
I've done it
adverse
once.
issues.
I've done it with actually subdural grids, but it can be just difficult to get that time slot. So if you have a child who you put the SEG in, I would love to get an MR, but knowing that the first thing I want to do is just figure out where the electrodes are and get them to the monitoring unit as soon as possible. Like I don't want them to hang out.
But of course,
but that's awesome that you can do that.
Yeah, but I mean, logistically, we don't have them hang out. We wouldn't have a disruption to our monitoring period. So we arrange an MRI. This is all pre-operatively planned. We arrange a post-operative MRI under the same anesthetic setting. So they complete surgery, they go right to the MRI suite. So there's really no downtime. I mean, it is an additional 35 minutes that they would be under anesthesia and undergoing imaging. And, I really don't think that it would subtract from their monitoring time with any significant degree. So
that's awesome.
Yeah, I mean, I think John, just to second John, Amar here, but I thought, so it depends on which system you're using. So we are here at Nationwide, we're using Dixie, and Dixie is actually don't have any, they will not support you on any MRI scanning of their electrode because they have not gone through any FDA approval, nor here, nor in Europe. And in Europe, I think none of their electrodes have gone through MRI. In fact, they were surprised when I talked to them about it. And they're like, we don't want to hear about it almost. So we have probably the largest series of post-op MRIs because all of our patients are doing it. But there's a lot of hoops that you have to jump to. You have to convince radiology to do it, which our radiology department has been great with that. But we have to consent the patients for them. We have to add a little consent in the chart. The electrodes cannot be looped. And the Dixie electrodes are extremely long. So that's part of the reason. Now, if you're using other electrodes, they have a lot more experience with imaging in different centers like AdTech. So it depends on the electrode you're using, but technically speaking, it's not. Now, the reason why we really do it is because for Curie registration for the neurologist, it helps them a lot in terms of relocate if they're going to do any source localization and matching to the pre-op EEG to actually have the electrode and the MRI. It does add a lot. So when we do the CT registration, like for cognitive research and stuff, when I want to localize the electrode, the CT is enough. The MRI probably doesn't add much, but it's really nice to be able to see that there are no strokes, no complications from the implant. If you have a patient who's waking up with a weakness, if you're implanting like a precentral gyrus with SEEG, which happens often, and you're always sitting there. So if your radiologists are open to it, you probably can do it. But the company cannot even use the data, because I talked to them, I was like, well, can we, give you this data and maybe get the FDA approval, but it requires still modeling and tens of millions of dollars to go through the system, so it's not going to happen.
It also provides some measure of reassurance. Matt Smyth already had talked about sending these patients to the epilepsy monitoring unit, which we're comfortable with. But I think having some imaging adds an additional level of reassurance. I mean, the CT scan that we get intraoperatively is of really poor quality. You can't really see, parenchyma or intracranial structures, and that really that's just for confirmation of trajectory. So it does provide some additional measure of reassurance of having them go up to the epilepsy monitoring in a less monitored unit. So
And Manish, for that CMN comment, if you want to share your placements, we have a bunch here too that I've been looking for a bunch of people who are willing to share their MRI post placement to see efficacy and placement. I think, we've been looking for people to like collaborate. So honestly, that's a great idea. It really is needed.
Yeah, no, I'd love to do that. I think if we don't do that and we're not honest, one of two things will happen. One, the overall efficacy will look like it's not great. And the probably will happen is the insurers will do what they've done with the Model 106 and the Sentiva generator, and we'll start to bat that down.
Yep.
Or two, people think we're dishonest, and then this problem with the community neurologists not referring patients will happen. So it's just better off that we do it right from the start. So I'd love to collaborate.
Yeah.
Hey, Jared, back to your case real quick. I think you mentioned that the patient developed a hemiparesis prior to your SEG implant.
Yeah, I don't know when that developed, but it had been there over time. She had some weakness on the contralateral side, and there's not a good explanation for it because the frontal resection is a good distance away from motor, and there's no lesions to explain why she has a contralateral hemiparesis. But
that part didn't fit. I didn't quite understand that. And I do remember her, so thanks for taking care of her so well. It's expertly done.
They've been very happy with everything over the years.
Any more trainee questions? Well, I mean, this is spectacular. I learned a lot from all the talks. So thank you guys for giving your talks. I'll turn it over to Professor Leonard.
Well, I want to thank everybody for taking the time to participate and spending the time with the presentations and discussion. Matt, thank you for a very well-rounded, broad topic in a very short amount of time. And thank you to our three presenters. This will be up on the website, and I will be emailing the rest of you because as you can tell, this is being recorded. And I appreciate everybody's time. Look forward to the next one here in about a month and a half. Thanks much, guys, for your time.
It's good to see y'all. Thanks.
Thanks, everybody.
Thank you.